Well, hi, George. Welcome to the show one more time.
Yeah, I'm back from Italy, so now we're doing it back from boring New York. We just
Wow.
recorded 4 podcasts while I was away in Italy. It was very cool with the nice backgrounds. This is the usual background.
We have two wonderful guests today. We're going to talk about direct primary care in the pediatric arena, Dr. Hertz and Dr. Mistovich. Keili is their first name. And we're very excited to have him on the show. We had Dr. Gross, who is going to be speaking today at 2 and gave us some hints on what DPC is. Now they're going to share with us how that works within the pediatric space. I think it's very exciting, maybe the future of primary care. Welcome, Drew.
Thank you for having us. We're excited to be here.
Welcome, Keili. It's a pleasure to have you here.
Thank you. We're excited to be here.
Thank you. So let's start by the simple thing. You stood up a company called Thrive Pediatric Network. What is Thrive Pediatric Network? What does it do, and why do we need one?
Well, Thrive Pediatric Network is the first direct pediatric care network in the country. Direct care or membership subscription model care is growing rapidly across the country. It's mainly in the adult world because employers and Medicare Advantage are starting to pay the subscription fee as well as individuals themselves who realize that the traditional primary care model is not working for them. So direct care in general, I think you had another podcast on it, as you just mentioned with Dr. Gross, but you pay a monthly subscription and you get unlimited care. Some people call it concierge, but it's really different than concierge medicine. Concierge medicine, you still bill insurance. In direct care, it's just you and the patient's insurance is not involved. So this has been growing for about 10 years and mostly in the adult world. There is family medicine doctors that are doing this. There are pediatricians that are doing this. However, there is no network. So every time a pediatrician decides that they want to go into direct care, they need to start from scratch. Keili started a direct care practice almost 2 years ago now, so she knows how to do it. And she approached me because I've worked with networks before and said, let's create a network so we can decrease the barriers for doctors, for pediatricians to enter direct care. And I thought it was a great idea. Doctors, as you know, get no training in medicine in medical school or in residency or any time. So a lot of them don't want to run a business. At the same time, a network has all sorts of advantages for vendor contracts, sharing best practices, camaraderie, coverage for the doctors. Doing it alone is a lot of fun and you still get the advantages of direct care, but you don't get any benefits. You're on your own. So we wanted to start a network to allow more pediatricians to enter the direct care model.
Keili, and you've been doing this for 2 years out in Cleveland?
Yes, correct. Yeah, my partner and I started a direct primary care office in Beechwood, and we opened our doors in December of 2020 and have been thriving since. It's been a really, it was an uphill learning curve to really, exactly as Drew described, to really learn all the ins and outs, how to run a business, all the legality behind it, everything that we needed to know from a medicine standpoint. And so we did all of that on our own and, opened our doors in December, and it's been great since.
And just walk me through your office. Like you're two pediatricians.
Yes, so it is, 2 pediatricians. We have a much smaller office than is a typical pediatric office. You walk in the front door and it feels much more like a family room. It feels like you're walking into somebody's home. It's much more cozy and comfortable. We have a couch. We have a coffee stand. We have, artwork on the walls that's just very calming and soothing, both to parents and kids alike. You walk down the hall and on one side is our lab area. So we have the ability to do all of the labs that you would traditionally expect in an office, be it point of care testing or, we do phlebotomy, we do all of the testing that any typical pediatrician's office would be able to do. And then, further down the hall, we have 2 offices. One is mine and one is my partner's. And those are really structured to be super open and warm to our families. We want them, I have my desk and all of my files and all the books and everything that I would normally have in an office. And then across the room are 2 comfortable chairs, actually just regular furniture monitor. And on the side of the room is a exam table, which is meant to be kind of an afterthought. I don't want it to be the focus of the room. I want the kids to be able to run into the space and feel like they're not in a doctor's office. And so they're much more willing to engage, and their anxiety decreases, and the parents, are able to feel as though they're sitting there and having a conversation with me that is very calm, comfortable, not rushed, and can really sit and open and ask all of the questions they need to, while their kids are on the side of the room playing with the toys, building with the Legos, playing in the dollhouse, really just kind of enjoying their time there. So much so that sometimes it's hard to get the kids to leave.
And Keili, how many, not to take Herb's job here, but Keili, how many staff members do you have in your office?
Yes, great question. So you may have noticed I mentioned none, and that is because there are none. So when a patient shows up in my office, I am waiting for them because I am not running behind and I'm not seeing other patients at the time. And so I meet them at the door, and the kids come often running down the hallway to greet me, and we go down to the office together, and I do all of the vital signs and check them in and do everything, because there's no staff or front office desk person or anyone. So it's very much from the moment they walk in the door, they are with me the whole time. I do everything. I see them, from start to finish. And there is no time when families are waiting for me or having their care, having anyone else need to be involved in any piece of that.
And
Right.
so,
So let me interrupt Herb. I mean, why is this any different than my office?
Well,
Other than I don't go to the door to wait for the people and walk them in.
Oh, George, if I may interrupt, George, how long are your well visits?
We book them out for like 20 minutes.
So
6
there's
visits.
one primary difference.
Yeah.
My well visits are often 60 to 90 minutes.
You have to talk that much?
Yep. Because that's
Really?
how
I can't talk for that long.
well, it's often not me doing all the talking. It's the fact that patients and parents actually have time to ask all of the 500 questions that they want to ask you, but they don't have time to ask you. Or they think that they can't ask you because they know they've only got 20 minutes and they don't want to make it such that you're going to get further behind. So they hold on to their questions. It's amazing the things that people will talk to me about when they know that they have the time to do it.
Okay.
and how long are your sick visits?
So those can be, it's very variable. Some sick visits can be 5 minutes from literally the time they step in the door until they're out the door. I spend a lot of time talking on the phone and texting with my families. And so I already know why they're coming in. I'm the one who told them to come in. I know all of their symptoms and everything that's happening, so they can come in. I can check their ears, look in their throat, do a quick exam, and diagnose an ear infection, and then they're on their way. And so it can be very short, or if it's a more complicated issue, we may spend a long time just kind of really hashing out all of the symptoms, the whole review of systems, really going through it all and getting down to what's going on.
And Keili, if you diagnose that ear infection in the office, or the pink eye, or the diaper rash, what else happens in the office?
So we have the ability to actually dispense medications from the office as well. So not only is it a huge time save for them to come in and see me, they're not taking off 2 hours of work to sit in the waiting room while, their doctor's running behind. So it can be a quick visit. And then I'm able to prescribe them their amoxicillin or their drops from the office, that I hand the drops to them, and then they walk out with everything in hand and they skip a visit to the pharmacy.
And is that part of the one fee a month, the medicines too, or is that separate fee?
So the medicines are separate. We bill those at essentially at cost to the family. So, in medications, when you purchase them through the vendors, are exceptionally inexpensive. And so we are able to provide them with, at least as low of cost, if not less than what they would get it from the pharmacy.
Yeah. I mean, generics would be $3, $5 for a course
Yeah,
of amoxicillin for 10 days. Yeah.
Mm-hmm.
And do you keep the charts in paper, or do you have an EMR system that you use?
We have an EMR system. It is a system that is essentially set up for the direct primary care sort of model. It is a much more simplistic system than what you would expect with Epic or many of the other types of large EMRs. And so it serves our purposes in that it has the billing systems built into it, as well as has the ability to, keep all the records, all the demographic information, everything else that we need, all the notes, all the medication distribution, the electronic e-prescribing, pretty much everything that you would need. In addition, it also allows us, it has an interface that allows us to text with our families. And so those messages will also be directly input into the EMR as well. And so all of our communication is essentially able to be in one spot.
Great.
Why would you need billing information if you don't bill insurance?
It's for their membership subscription billing.
Oh, okay.
And the membership, the billing is also used if you order diagnostics. You can send the insurance information to the lab, to the radiology, and also we'll talk about vaccines in a minute. But you need their insurance information in order to get the insurance to cover the vaccines.
Oh, yes.
And how many patients do you aim to see a day?
That is also very variable. I would say on average, it is usually 3 to 4 patients a day. A busy day is 8.
Okay.
And some days I see 1 or 2. So it's very variable, but significantly lower than what is used to be my life.
And what is the size of the panel that you need to make this, work for you financially?
We are aiming to have somewhere between 250 to 300 patients per doctor.
Okay.
Mm-hmm.
One thing that always comes up when you're talking DPC is what happens to the vaccines? Because vaccines are very expensive. So how are you guys managing vaccines?
So there is there's a third-party vendor who actually has partnered with a lot of DPC practices. And the way that system works is that they will send a supply of vaccines to us. We administer the vaccines, and then essentially they are paying us an administration fee and also taking a percentage of that. So they make money by us giving the vaccines, and we don't have to upfront the costs of purchasing the vaccines to begin with.
And the third party bills the insurance then and accepts the money from the insurance.
Mm-hmm.
And so the parents benefit even though you're not in network anymore with the insurance company.
Correct. Yes. So this vendor has contracted with most insurances and is able to thus just bill like any other office would be able to.
It's interesting because the insurance companies kind of shy away from that, right? Just to force you into their networks. But that's a great solution because that's always something that concerns people. Who is your target audience right now? How do you grow the practice? Do you grow it through, parents networks, or are you reaching out to employers, that have a lot of young people with children, and showing them the value of the practice?
So I'll start with answering that with what we are currently doing, and then maybe Drew can kind of add in what we look to do with the network kind of moving forward. So as far as my current practice, the vast majority of my families are patient referrals. And so it is other families who are part of our office who love their experience and thus refer their friends. And so most of our growth has been from that. The other portions of it would be through schools. We have done a lot of school outreach and are, for example, doing vaccine clinics. We've done COVID clinics through some of the local schools. And so we've gotten a handful of patients that have met us through those routes. And then otherwise just some social media to local parent groups and those kinds of things. But honestly, word of mouth has by far been our largest referral source.
Do you get any pushback over the monthly fee? I mean, people are already saying, I pay so much in insurance. Why do I have to pay more?
That is a very common question that I get. And I think once you kind of break it down for families, while they are paying for their insurance, there are many additional costs that they incur by going to see the doctor, between copays and between all the time that they take off of work to come in. And not to mention that our ability to save patients from needing to go to urgent cares and the emergency room is, we'll pay for an entire year's worth of membership in one phone call. And so I think in part they see the value from all of that after this conversation. And I think in part because they, when you think through what does an average family spend money on to begin with, when you compare the cost of being a part, the subscription for this membership model compared to many other things that parents will spend for their children, the value is clear.
You think about it, Herb, too, in their membership, all the point of care testing is included. They get the discounted drugs. If you add it all up, if they have 4 or 5 sick visits a year, or if they have a chronic disease for which they're coming in 3 times or 4 times a year, ADHD to be managed, the membership pays for itself. It really does. And if they have because they have high deductible health plans, so they're paying for every visit. The insurance is not paying for it until they reach their high deductible. They're paying for it. So now, rather than paying their high deductible, they're just simply paying their membership fee. So for a lot of parents, it's a wash or even save them money.
Yeah. And what are you going to do in the future with the network as far as attracting big employers?
Well, we've started talking to benefit brokers. We've started talking to people who, there are many networks around the country that pool employer benefits. So they're not really brokers, but they're group purchasing for benefits. And so we've been talking to them. And it's interesting, as pediatricians, as I speak with them, there's all sorts of focus on adults and the benefits that adults are going to get, and how are they going to decrease health spending, the cost of healthcare for their adult employers. Nobody's radar is talking about kids. Now, certainly during the pandemic, kids have risen in people's mind because of the childcare crisis. People couldn't find childcare when they were at home working and the schools were gone and all that. So they're worried about those benefits for childcare, and hopefully they're also going to be become aware that they need alternatives to get kids better care. The current system, excuse me, the current system is not really helping our children. Kids are getting more and more chronic diseases. They're sicker. They have behavioral health problems. And it's harder and harder for a pediatrician to manage all of those issues in the time allotted. So hopefully this is one model that's going to help to address the challenges in our current healthcare system. I don't know if it's the only one that's going to help, but we need to start trying new things.
I would agree with you. I think that the model is broken, and no one really thinks about the kids. They're an afterthought, and that's been a problem since Medicare and Medicaid started.
Correct.
And it hasn't, it's never been resolved. And as pediatricians, we have dropped the ball. We have not been strong enough voices that children deserve better than what they're getting. They should not be an afterthought. They're the future
Right.
of the country.
We hope to engage employers, and we do have one Medicaid managed care plan that's interested in piloting with us. It's on the back burner a little bit, but I've heard from them several times, just because it's going to have to be a slightly different model, with the Medicaid plan paying the subscription as Medicare Advantage does for seniors. So hopefully we will get to that sometime in the next year, but right now we're focusing on schools and direct to consumers and building the network.
I think they're talking about in the Medicaid, they're talking about like a capitation model, which is, I guess this is almost like capitation.
This is a primary care or a general pediatric capitation model,
Yes.
right? Because we're not going to take capitation or risk for hospitalization, emergency room, chemotherapy, all those things.
Right.
We'll never do that. But like in Medicare Advantage, they have a primary care cap. And so that's what it would be like.
Right.
And how do you envision collecting data to show quality? Because once you get, Medicaid contracts and big employers, they're going to want to see some quality. And then some of the efficiency of the DPC model starts getting lost if you have to jump through all the hoops, just like regular practice.
It's going to be a balancing act. You're absolutely right. We will not submit claims, but the EMR that we are utilizing still drops CPT codes. So you're still making a diagnosis and you're still getting a CPT code. You're still tracking immunizations, well visits, anything else that you want. So as long as the doctor will still pick diagnoses and have some clicks of what they did, we can track data. Hopefully it will never become as cumbersome as it has been when you're submitting claims. But that is yet to be determined, Herb. It's a great question. But from the get-go, we knew we wanted to be able to track that data because you're going to have to be able to prove that this model is providing at least equal quality to the traditional fee-for-service model.
And I think Lee Gross had a really good analogy. This is the first time I heard it explained like this. He said models like One Medical are like a fast pass at Disney. They're still billing the insurance company, but for the $200 a year, you get put in front of the line. The DPC model is very different. Everybody's treated the same. And sometimes you even negotiate discount rates with radiology and labs, which are significantly less costly to the patient than if they use their insurance card. Because at the end of the day, they still got to pay the first $5,000. And that I think is very helpful for the parents. So you guys don't deal at all with insurance. You just say this is the monthly fee, and we're done.
That's pretty much how it goes. And,
Yes.
we certainly will need to take their insurance as Drew mentioned, we use it for the vaccines. We will submit it whenever we're putting a lab requisition in to go to the lab for certain things. But as far as our purposes, we don't have a use for insurance.
Right.
Okay.
What do you do? What do you do if there's a hardship, a financial hardship?
So we have the ability kind of built in with the model that we're able to discount memberships for various reasons, and a certain percentage of our total memberships can be a discounted rate. And we certainly have offered, many of those. For example, I have a family who has 6 kids now. 3 of them they just recently adopted from Haiti. And so all 3 of those kids I'm essentially taking on pro bono. And so their membership is much less than it would be if they were, any other family.
And so do you have like your fee schedule? Is it like X amount of dollars for the first kid, a little less for the second, less for the third, or everybody pays the same?
It is a system where we have the rates based on age and siblings. And so a newborn is a more expensive child than, say, a 6-year-old, certainly mostly based on the amount of time that it goes into taking care of a newborn compared to an older child. And so as kids get older, their cost goes down. And as there are more kids in a family, the cost per child goes down. And then we also have a cap for a family. So that way they are, it's limiting the total cost overall.
Related to newborns, if I may, Herb, back to George's, Common House is different than my practice. Also realize most DPC pediatric practices across the country do home visits for newborns. And that is very different, loved by families. Vaccines are given in the homes for the first set, sometimes the second set. And that's very different than what traditional pediatricians can do. And it really allows you to get to know the families better and to really make a safe environment. You're really getting to know the whole family and the environment in which the kids are going to be raised.
Yeah, no, home visits are a nice thing. I agree with you. But there's a lot of complexity to it. What do you do about like vaccine stability?
So that's part of the learning curve of this model, is that you need to learn all of the rules about how to transport vaccines and all that. And it is actually more simple than you would think. Most of the vaccines are pretty stable, and we transport them in a cooler, and we can use a thermometer sensor. Most vaccines are room temperature stable for a period of time after you after you take them out of the fridge. And so it is it's a very doable thing.
Um, it, I like the idea of home visits, but do you have a radius? Like, because, I live in Northern Virginia, to get from here to Tyson's Corner, where there's a big shopping center, it could be 30 minutes or 2 hours.
Mm.
So I don't know in Cleveland how the traffic is, but do you have a radius? Like if they live 20 miles away from your office, that doesn't seem like you could go there and come back and still do it, or you will?
It depends on the situation. We kind of have a general radius that will advertise, if you will, of how far we're really willing to go. But then that conversation evolves with each family. And we may do an abbreviated model where we'll go there for the first couple of visits right after they come home from the hospital, and then they'll start coming to the office sooner, or some, variation on that. I would say for the most part, I'm willing to go around 30 minutes or so driving time each way to see a family. And truly for the families, home visits are invaluable. Like, that is one of the primary things that people will talk about as being such a benefit to them, that they don't have to leave their house when they come home with their newborn, is, beyond valuable to them. And I love to see families in their homes. I love to see what they are doing and where the kids are sleeping and how they're all interacting and just what is the home like. And it really allows me to take such better care of my families, because I get so much more information than they would ever tell me in the office.
And do you go to the hospitals at all anymore, or?
Yes, I do. I have always gone to the hospital, and so that was not a change from when we started this practice. And so we have two major hospital systems that we will go and see our newborns in, and we care for them in the hospital. If someone delivers outside of that, then we will, be in touch with the pediatricians who are taking care of them in the hospital, and then see them the day that they get home.
I'm trying to how to politely ask this question. Do you ever get a little concerned about doing a home visit as far as your safety and your own security?
It is a good question to ask, because it was definitely something that we thought about when we started this. I would say to date, I have never had any concerns around that issue, a safety issue particularly. We do meet our families and talk with them in the office and have them come in and spend time with them to really make sure that they're a good fit for the practice, as much as our practice is a good fit for the family. And so I think that experience really gives you, a sense of who your families are, and kind of what that experience is going to be like. Also, most of our families are from referrals from other patients that we already know and have a long-standing relationship with. And so that also makes us feel safer.
We've
Okay.
thought of, as we've talked about, this thought of requesting or having a requirement that 2 people have to be at the house other than the baby. So 2 adults. We haven't implemented it yet, but that's one way we've thought about addressing that concern.
Yeah.
It'd still be
'cause-
a concern, but it'd be one way to address it.
Yeah, because these big companies like Sears, when the Sears repairman comes in, for safety of the repair person and for tracking of work, the van has a GPS system that if he's supposed to be in the house for 30 minutes repairing the refrigerator and he doesn't get back to the car in 30 minutes, they'll give him a call. I thought that was fascinating. Sears, they just want to make sure their employees are safe, or not sitting there, drinking soda with the family and, not doing anything while they're getting paid. How is pediatric direct care different than, say, family practice direct primary care for children?
You want to take that, Keili, or you want me to?
I'll start. So in my mind, it is similar to the distinction between how is family medicine different than pediatrics. With pediatrics, our sole focus is kids. That is all that we think about. Everything that we do, all of our services, all of anything that's involved in them is the only part that, that's the primary thing that we're worried about, as opposed to family medicine, where it is, it's across all ages and spectrums of life. And so the focus is much more broad than is just focusing on our kids. And so I think that's, in part why pediatrics became its own specialty to begin with. And so I think those same sorts of differences apply in this model as well.
And I
Okay.
think as we talk to family medicine doctors in the direct care model, a lot of the family medicine doctors don't see the young children because they don't want to deal with the vaccines, as you brought up. They don't do home visits. And the fees for children in the family medicine direct care models are much lower, because I don't think that they really are focusing on the adult care. And pediatric care, is much higher touch than adult care,
Right.
especially for newborns. In the first 3 years of life, you're talking to families all the time. And so it's a very different mindset, I think, between the family medicine and the pediatrician. Just as Keili said, all the pediatricians do are kids. That's all they think about. And it's their focus. They're really looking at development and whole person care.
Yeah. Do you have any questions, George?
I'm thinking, I mean, it sounds like what you're doing is what doctors should be doing anyway, minus the house calls. I don't know my practice used to do house calls back in the 60s, I guess, but I don't think I could do it. I mean, insurances don't pay for house calls, so maybe they do now, but it's something that I don't think, something that I would like to get involved with. But the rest
Many
of
of
the
the direct care
Mhm.
practices simply say this is old-fashioned medicine practice the new way.
yeah,
And it's really what it is. It's trying to get back to the way medicine was, where you had time and the relationships before the insurance companies and the health systems started implementing all these rules and regulations.
right. But in my mind is, I mean, you're supposed to see patients, you're supposed to interact with patients, you're supposed to provide service. This is kind of like what I think we do, I think.
I think
Yeah.
it's what pediatricians try to do
Uh-huh.
and can't do in a traditional office. I don't think most pediatricians, who are seeing 30 patients a day, want to do all the things that I can do, but simply don't have enough time or bandwidth to actually do them as
Right.
well as they want to.
Well,
And
yeah,
so, as we like to describe, it's kind of this idea of moral injury, that you have a job that you want to do and you are trying your hardest to do it, but you can't. And that leads to a lot of dissatisfaction, I think, for doctors in their primary jobs.
Yeah. I mean, even trying to take care of a kid who's constipated. Constipation may be a very simple problem, but it's not a one visit problem.
Mhm.
And it's a lot of trial and error. And people don't want to keep coming back and having to pay you whatever their deductible is to talk about it. And you can't do it on the phone for free, because you got paying patients that want to be seen.
Mhm.
So what do you end up doing? Well, you end up sending him to a specialist because they got more time to deal with the constipation.
And they
That's
have a
not good.
bigger team, and they have bigger and they have an educators team. That's a fabulous example. Her constipation, it's such a common problem, and it takes time to get it right. And not only that, her with constipation, it's a great example. You have to have trust between the parent and the doctor for them to really trust you that this is not, a fix this week. To fix constipation, it takes months, and they have to trust you that you're going to be with them. And then they need to make sure they're seeing the same provider over and over and over to know what's been tried, what hasn't worked, the nuances. And often in a large practice, just the way it's set up, you might end up seeing a different practitioner, provider, for some follow-up appointments, or when things regress and the onchoparesis comes back. It's a brilliant example. Her
Well, it's a very easy disease to take care of or problem, but everybody has their own recipe of how to deal with a constipated kid. And it takes a lot of talking
Mhm.
and a lot of, titrating,
Mhm.
because
Handholding.
it does not work the same way for every kid. And that's impossible to do when you're doing regular insurance. It's just not possible. So you have to send them to the GI specialist, which is much more expensive and a waste of time and money, but you have no choice.
Just think about the time it takes to educate the parent and or the child, depending on their age, about what's really going on with constipation.
Yeah.
That-
What do you
that's-
do about like weekends, evenings, holidays?
Good question. So that's one of the benefits of having a partner, because we're able to take time off and cross cover for each other when we need to. On the weekends, it's interesting. Our families have evolved such that they have a very high level for respect for us as humans and people, and recognize that we actually have lives outside of taking care of their child. And so truly most of my contact with families is during the normal business day. I will get families who call or text me in the evenings and on the weekends, but the volume of that is significantly lower than one might expect. And it's because my families recognize that they really want me to have some time away and they don't want to be bothering me. And unless it is something that is urgent and time sensitive, then they'll wait and they'll ask me on Monday, or they'll send me an email instead of texting it to me that day. And so it is much more manageable than most people would anticipate. And then on times as when I do need to, go away for a weekend, or I'm taking a trip somewhere or whatever, then my partner will cover for me for those, that time period, and vice versa.
And that's the other reason we want to network her, is so that if a single doctor wants to set this up somewhere and they don't have a partner yet, we can cover for them. We have one EMR system, we have one coverage system, and that's our intent, one of the intentions of the network.
What, Keili, were you in a normal dysfunctional practice before you can? I mean, all our practices are dysfunctional because we're operating by rules that somebody else decided, and we can't really focus on taking care of what we want to do, which is take care of the kid.
Yeah.
So we're jumping through hurdles, whatever it is, a medical home, do your boards again, do this, do that. It's all waste of time to make somebody else rich. But at the end of the day, my patient's suffering because I'm not in the exam room. So were you in a regular practice before this and you just had enough of it?
You could put it that way. Yes. I was in a large independent practice of approximately 12,000 patients and around 10 doctors or nurse practitioners. My personal panel was around 3,000 kids. And so, yes, I was in a large practice, busy practice, and got to the point where I could not keep doing it because I knew that I wasn't doing the job that I wanted to do. And I couldn't take care of kids in the way that I wanted to. So I had no choice but to try to do something different.
And my
Yeah.
story is, I tell Keili, one time I was very upset with her. So I used to be in a traditional practice. I ran practices, but I was in one. And, in my half a day, I'd see 15 kids and I'd be so proud of myself. My boxes would be checked and my quality scores were good. My patient satisfaction scores were good. My billing was done. And I was like, I got this. And then I met Keili and heard about what she did. And I realized that I was putting Band-Aids on problems and spending a lot of time managing things over the phone later, and not during the visits when it'd be more convenient. And after talking to Keili and learning about this model, I could no longer enjoy the other model because I realized that I really wasn't doing as good of a job as I thought I was. I was putting Band-Aids on all the kids.
What else have we not talked about that you guys think is important for our listeners? And most of our listeners are pediatricians.
Keili, can you talk a little bit about your work-life balance and what's happened to it since going the DPC model?
Sure. Yeah, I was going to say that I think, we spent a lot of this time talking through why is this better for patients and how does it, really what are the benefits there? But I think so much of the benefit is also what is it like to be a pediatrician in this model now? Not only do I no longer experience kind of the moral injury of taking care of families and trying to be the pediatrician that I can't be, I now have my work-life balance is so dramatically improved. I am able to, I have a daughter who is 10 and I'm also married to a surgeon. So my life is busy and it's also very unpredictable in that I never know when does the surgeon come home? Who knows? Maybe when do they leave? I don't know that either. When do they show up for things? And it's always a big question. And so I am now able to be present at all the things that I need to be present for. And so if that means that I have a performance at my daughter's school that I wanted to be able to go to. And I just heard about it the week ahead of time. In a traditional office, I can't just take off that time and show up, but now I can, right? I can schedule my patients around whenever I need to be gone. It is up to me. I decide when I see them. And so I'm able just to block that time out. I go to school, I come back, and I'm back at it again. And so the balance of being able to be a mom and take care of my family in the way that I need to, and also take care of my patients in the way that I need to, it is so much better than I ever imagined that it could be. I often tell other pediatricians when I'm talking about this that you could not pay me enough to go back to practice medicine the old way. You could not. I am so much happier, and my family is happier. My daughter is happier. She sees me more. I am not charting at 10 p.m. and not sleeping and trying to figure out what I'm going to make for dinner the next day because I haven't had time to go to the grocery store in a week. None of those things are my life anymore. And so it is so much better and so much improved.
Well, to me, my dad's a lawyer, and they just scratch their head as to how pediatricians work. It's kind of like you're trying to get it back to where we're professionals. A lawyer would never see 30 clients in a day, not knowing what they're coming in without ever looking at their file before they sit down with you. And when you go into a DPC model, then you actually have a professional relationship with your clients. You know what that file has. And when you sit down, you've had time to even maybe look something up before you talk to them about what the plan of action is. And that has to be much better quality, whether you're an accountant, whether you're a lawyer, whether you're a pediatrician, because you know your client, you know their needs, and you know what you can do for them and what you can't.
Absolutely. I could not agree with that more. I have found that the depth of my relationship with these families is so much greater than it ever was before. Even families that I saw regularly, you know so much more about them. You know how they're going to respond to all of the things that you are telling them. You know what they need you to talk about. You know what they're nervous about. And so all of those parts, and it's almost as if every one of these families is part of your family because you know them so well. And you're right, you truly do. I actually have time to read and do CME and think about things and look stuff up as I'm going through the process of my day. This is not I will try to do it in the evenings after I put my daughter to bed when I am tired. I have time during my regular day just to learn. It's amazing.
Well, thank you very much for joining us. I personally think that this is the model of the future.
Yeah.
And it brings back some sanity to taking care of patients. And I think it improves quality for the patient. And it has been shown that it decreases cost. That's been shown over and over again. These high deductibles to go to your primary care physician do not decrease cost. They actually increase cost. When you take that barrier away, people don't go to the urgent cares and the ERs and the specialists as much, and they're healthier and they're not spending as much money.
Right.
So thank you for taking time off your busy week to be with us. And we wish you the best of luck. It's very exciting. Maybe you'll come back and tell us how you're doing in a year or two and what you have found out.
Great. Thank you so much. It was great to be here.
Likewise.
Thank you.